I want to start off by saying I sincerely respect all the work that everyone here is doing. And in addition to that, my goal whenever I talk about the needs of transgender clients is never to change anyone's personal beliefs or views or opinions. I'm a licensed professional counselor in Connecticut. I'm a licensed mental health counselor in New York. And part of our code of ethics specifically indicates how it's unethical for me, the provider, to impose my belief system on anyone that I'm working with. So I'm not trying to impose any of my beliefs. Within that, we are going to talk about some opportunities to assist transgender and gender nonconforming clients. And this information is based on our current evidence. That doesn't mean that things won't change in the future. While we're starting on this, I completely, fully respect that this is a hot topic. And my best attempt at having this discussion today is to try to have this discussion in a way that removes politics. So every person here is working in the field, and you're allowed to have your own political opinions, your own personal opinions. My approach is doing what is best to meet the needs of the people that we're working with. So it doesn't matter what I think as a person. I'm obligated as a clinician to create a warm and inclusive environment, which allows every client I work with the opportunity to change. I've been working in the field since 1998. I've been the director for several different programs, and I started working with transgender clients back in 2005. In 2012, I became the director for Westchester Medical Center's Gateway program, where we focused in on treatment of the LGBTQIA plus communities with a heavy emphasis on working with transgender clients. When I first started working with trans clients, I got myself my own supervision because the individuals I worked with, the supervisors I worked with, had no experience working with trans clients. So also within that, whenever I meet with the client, I don't disclose any personal aspect of myself. I don't answer personal questions. I will usually do my best to try to assess what it means to the client. But specifically when I'm talking about working with transgender clients, and if I'm presenting on this topic, I will disclose to the people I'm working with my own identity. And as everyone can see, I'm a white male. I am cisgender, means that my gender identity is my sex assigned at birth. So I'm a cisgender white male. In addition to that, I am heterosexual. A lot of times people assumed I was homosexual working with people from LGBTQ plus communities. I'm heterosexual, and I'm also a born again Christian. I sing and play guitar in my church band. I say all these things to indicate how you can be who you are and still provide good quality care to various people from marginalized backgrounds, especially if you take an approach of cultural humility and a willingness to meet people where they're at. I just ask that if anyone has any questions or any comments, please feel free to jump in. I just ask that everything be respectful. And like I said, I'm willing to hear everything. Also, despite the fact that I've been working in this field since 2005, specifically with trans patients, I am always learning. And our knowledge currently at this time is imperfect, and these things are always updating as well. So if you have any feedback or if you think I'm getting some things wrong, please feel free to reach out to me. I have no problem with receiving feedback. So we're going to get started. We're going to go today about till about 1:15. But if anyone, like I said, has any questions, feel free to reach out. And I'm also going to give you a full toolkit about how to work with trans clients. So you're going to hear me complain a lot today when we talk about this because I take this work very seriously. So when working with trans clients, I've worked with tons of clinicians who actually did not have any training or education about how to work with trans clients. So for me, as I got my supervision, specifically from a doctor who had his degree in sex therapy and specialized in trans work, one of the first things I had to do was read the WPATH Standards of Care. That's the World Professional Association for Transgender Health. They are the current like foremost like experts on working with transgender clients, and they receive a lot of criticism. I don't think the criticism is unwarranted, but with that said, though, they do provide an awesome framework as to the mental health counselor's role, the social worker's role, the doctor's role, the surgeon's role. So I work with a ton of people who have helped people along with their transition, yet they've never read the WPATH standards of care, and that is offensive to me. So I'm going to make sure that everyone here has access to the WPATH standards of care. In addition, I'm going to make sure they have access to information about hormone replacement therapy, which I would share with my clients, and then examples of letters to help people have a formal name change, or if you need assistance with linkage with formal surgeries or hormone replacement therapy, I'll provide letters for examples for those. So once again, feel free to jump in at any time. This training is usually done over the course of about 8 hours. So I'm going to be fast forwarding through a ton of this. So I apologize about that. So also, I can't stand hearing my own voice over and over again. So if anyone wants to jump in, please feel free. I'm not going to get mad. So today we're going to talk about we're going to identify how the needs of transgender and gender nonconforming individuals differ from gay, lesbian, bisexual, and other communities. Notice I use the words communities with an S. A lot of times people are gay, lesbian, bisexual, intersex, trans, asexual, non-sexual, pansexual. They often get lumped into one big giant community, and that's not the case. Every member, every letter within the when we put this all together, every letter has their own needs. So we'll also identify the process of treatment for individuals who identify as trans or gender nonconforming, and we'll list ways we can create an inclusive and safe environment for trans clients. Now, once again, I'm not going to get mad. Does anyone have any concerns about working with trans clients or gender nonconforming clients? I've worked with children, I've worked with adults, and whenever I do this presentation, whenever I ask if anyone has a problem, 99% of people say they don't have a problem. And yet when they describe their experiences, they will say a ton of words which are not affirming or might be disrespectful. So one time when I was presenting this, I did have one gentleman once be honest and say, I'm not comfortable with it. And I was really thankful for his honesty because he really had a heart of wanting to support the people that he works with. And he allowed me to support him to get out of his own way to meet the needs of clients. So does anyone have any concerns about working with trans clients? Judgment-free zone. Could be saying the wrong thing, could be having parents angry. I remember when I first started, I was worried about clients having surgery and then they would sue me. Anyone have any thoughts? Judgment-free zone. I know we have like 40-something people in there. There's got to be someone who has a thought. Like I said, I'm not going to get mad. Okay. Well, feel free to jump in. You don't have to necessarily put anything through chat. So to start with, like a lot of people will kind of feel that the transgender cultural phenomenon is something that happened relatively within the last 10 years, but trans individuals have existed in all cultures and all societies for as long as like people have been around. Now, there are various identities and various ways that people can find themselves. For some individuals, they just might want to live in their identified role. They may not want hormones or surgeries, but other people might want hormones and surgeries. Also, trans people can have a lesbian, bisexual, gay, or heterosexual identity. Within that, we'll talk about how we make sense out of that. And unconditionally, trans people have equal rights to healthcare as others. And transphobia exists at varying levels. Now, with that said, especially when I was the director for the Westchester Medical Center, in New York is a very liberal state. And every clinician I worked with, they said they were so happy to support trans people. And yet I would get calls from every clinic around Westchester with clinicians who would say that they're very supportive of trans people, calling me up and saying, you have to work with this person because I don't know what I'm doing. And that would mean this person would have to wait about 6 months because I had a huge wait list of working with trans people. So I would say, I'm sorry, I cannot see this person right now. And then the counselor or social worker or psychologist on the other end would then be angry with me that I could not see them. And they would say, well, what am I supposed to do with this patient? And my response was, well, I guess you need to read a book. And so I take this work very seriously. So you're going to hear me talk a lot of crap. All right. So with that said, I'm going to keep going. I usually like to start off specifically with how we actually show empathy. So within working with marginalized populations, we know there's a lot of literature that talks about the benefits of having representation within the people who are providing the services and the people receiving services. While we talk about the benefits of that representation, it's still not there yet. The vast majority of people providing mental health services are white women. And that's okay. I'm not trying to bash anyone. I appreciate every person that's here. But with that said, we can try to tell someone we care, but that doesn't mean anything. And in addition, we can share our own experience, but that does not mean anything either. So if you share your own experience, that doesn't mean that you know what the client is going through. I never assume that I know what any of my clients are going through. I never tell them I understand because I don't understand. But what I do is I show the client that they are the most important person to me. So I'm showing this graphic to conceptualize how we show empathy. So we all have instances where we're thinking about what we're going to say in our brain. However, sometimes it doesn't come out of our mouth the right way. And therefore, the person, like, what the clinician might hear is entirely different from what the client is thinking. And then I say what I think I heard, but that comes out of my mouth wrong. So what I do to close this loop and make sure that I'm truly hearing what the client is thinking is I use the ORS skills: open-ended questions, affirmations, reflective listening, and summarizing. What that shows to every client is that they are the most important person to me when I'm meeting with them. It doesn't matter what I think. It doesn't matter my own preferences. All that matters is that I'm here to help the client get better. So we're going to have just a quick definition of terms. So these are like just very limited definitions. So sex is biologic and assigned at birth. So a lot of times people will say biological male, biological female. I prefer using the terms like sex assigned at birth. Now, gender is the societal interpretation of individual sex. For many people, their gender identity is their sex assigned at birth, and therefore they don't conceptualize gender as being separate from their sex. With that said, a lot of people do. A lot of people have a gender identity, which is the sense of their internal identification and their expression of how they would have their observable and identified identity be within the social context. So gender variance and nonconformity, it's an individual's gender is unique or outside of the binary. Cisgender just means non-trans person or a person whose gender identity is their sex assigned at birth. So what I've seen happen is like the term trans it continues to grow, and it is an umbrella term. So as I was saying before, the gender identity is the internal sense of being male, female, or other. There are various identities that people can have. And the gender expression is the way the person communicates their gender identity to others. Now, a person can have a gender identity which is non-conforming to traditional binary aspects. When I say binary aspects, we live in a binary world. The vast majority of how our cultural institutions conceptualize gender is in male or female. So you go to the bathrooms, I appreciate that they have all gender bathrooms now, but traditionally it was male or female. You go shopping, it's male or female. So this is something that's been very ingrained in our culture. And trans people experience struggles within the LGBT communities, and I'll talk about that specifically. Now, one of the things that people get really frustrated with is about the having to provide a diagnosis. And I respect that because we do not want to, when working with someone who has a gender identity which is not their sex assigned at birth, we do not want to stigmatize the individual. For me as a clinician, when I would first start working with a client who identified a path of wanting to take steps for them to live authentically with their gender identity, I did discuss with them the diagnostic aspect. And I was very open, indicating like, hey, I could respect that this could seem like this is We are labeling you and stigmatizing you, and that is not what I'm trying to do. With that said, this diagnosis has to be provided, especially if we're linking you with additional services such as hormone replacement therapy or medical treatment. And when I say medical treatment, I'm not even talking about surgeries. I've worked with a lot of medical doctors who had no education and no willingness to learn about how to work with trans clients. So within that, I discussed the benefits of the diagnosis, and within that, indicating it's a marked difference between the individual's expressed or experienced gender and the gender others would assign to them. It must continue for at least 6 months, and it's manifested in a few different ways, such as strong desire to be treated as the other gender, be rid of one's sex characteristics, and a strong conviction that one has feelings and reactions typical of the other gender. What I don't like about this DSM conceptualization is that they're still looking at things in a binary. And I do expect that newer forms of the DSM are going to be a little more broad to conceptualize, as opposed to saying the other or opposite, to say outside of their sex assigned at birth. I think that's a better way of conceptualizing it. So within that, when I meet with people and I discuss this, I would say the vast majority, like 99% of the people I've worked with, have identified a gender identity that existed throughout their life that they didn't know, that they felt was always there. Some people knew when they were very young that the body I'm wrapped in is not the person that I am. Whereas other people had this feeling throughout their entire life, but did not know how to verbalize it until they met other people who also had that. So it's very rare I've ever met with someone who had experienced these symptoms for less than 6 months. And with that said, a lot of people I've worked with will view mental health clinicians, especially myself, as it would be the gender specialist. They would view me as a hoop that they have to jump through in order to get treatment. And I respect that. With that said, if you are working primarily with a trans person, you are not a hoop to be jumped through. You are a resource and a tool to assist the client with helping them find themselves. So there's so many different categories. I'm going to touch base on just a few. So we would see on medical records, FTM, that stands for assigned female at birth, but lives and identifies as male. Trans woman assigned male at birth, but identifies as female. There are people that live outside of the gender spectrum. We're going to talk about what that looks like as well. Now, what I see sometimes is drag kings and drag queens may be considered members of the trans community, and that doesn't mean that there aren't people who would be drag kings or drag queens who wouldn't also be trans, but that term is usually assigned to someone who is not trans. They put on this aspect of them as almost like a character or a break from themselves, whereas trans individuals would identify their gender identity as themselves. Other categories include multi-gendered, gender non-conforming, gender queer, third gender, two-spirit, or non-binary. Now, when I first started working with trans people back in 2005, I remember reading literature that said there were about 150 different genders. Now, I'd say like 3 years ago, I was reading some literature that said there are as many genders as there are galaxies in the sky. Now, that seems very overwhelming. And I want to be very open about this. I've done about 100 of these trainings so far. And in several of these trainings, I've had people who attended the trainings who had gender identities outside of their sex assigned at birth. And within that, I inform that the majority of people attending these trainings are most likely cisgender. So I'm not trying to take something that's very complex and make it too easy. But with this next part would usually be frustrating for people, as opposed to saying there's infinite amount of genders. I'm going to try to make this easy for you. Take a guess how many genders I say there are. Now, this is not literature specific. This is just a way to try to make it easy for the clinician and also easy from a treatment provider perspective. So take a guess how many genders I say there are. Some people said there's 150. Some people said there's infinite. Anyone want to take a guess? There's no wrong answers. It's okay. All right. To make this easier, okay, we have someone in the chat, finally a brave person, as many as there are people. So Michelle, I appreciate that. Yes, that very well, that makes sense. So, but the answer I give is 5. So people can identify as male, female, both, none, or other, but within this, to conceptualize this as a 3-dimensional box. And within this 3-dimensional box, people can identify fully here as female, fully here as male. They could identify as male and both, or male and none. So there technically are infinite genders within this 3-dimensional box. My job when working with a client who is interested in taking steps to live an authentic life is to do what's called gender exploration, where we provide the client with a non-judgmental, fully affirming environment where the client has the ability to find themselves. So this gender exploration aspects, I've heard some people say that gender exploration would be similar to conversion therapy, because conversion therapy traditionally for gay individuals was providing a noxious stimulus whenever the individual had a natural response to their sex drive. So for example, if someone looked at naked pictures of someone of the same sex, if they became sexually aroused, they would be physically injured to prevent that sexual arousal. My job when doing gender exploration is to never tell the client who they are. My job is to allow the client to explore who they are. When we conceptualize power and privilege, and we conceptualize living in a world that has systems of oppression, individuals who are cisgender have had their entire lives to find themselves. So throughout my own personal life, I've gone and experienced a multitude of transformations and expressions. Back in the day when I was younger, I used to be in a death metal band and I had really long, heavy metal hair, and I would wear leather and spikes. And with that said, people change, people find themselves. So I'm not saying that every person will have the same path, but within this, as we're living within a binary world, we want to help the client be able to find themselves, especially if their gender identity is outside of the binary in a world that doesn't understand. So to assist with this, I will often use the gender unicorn. This is one of my favorite things. Now, with that said, I just want to be very transparent. My theoretical orientation is cognitive behavioral therapy. So CBT is my backbone. I also have extensive training in DBT and motivational interviewing. And although I've worked with trans people since 2005, I've also specialized in a bunch of different things, and also working with sex offenders, murderers, rapists, people who've engaged in torture. So I've been the director for inpatient and outpatient units. So I have a ton of different experiences, as well as working with individuals who have random sexual fetishes and philias, even stuff that I couldn't have imagined, or there are no words to describe what their sexual fetishes and philias are. So when we are working with someone who has a sexual identity or gender identity, which is outside of what we'd say the binary or the norm, we just always want to make sure we're providing an affirming environment, which we're not providing judgment. So as I was saying, I'm a CBT person. I conceptualize this gender unicorn from a very CBT type of way. So on the very top, you see gender identity, and you see a circle on the left and an arrow on the right. So I ask the individual to conceptualize themselves. That circle on the left becomes a 0 for me, and the arrow on the right becomes a 10 for me. And I ask the individual to identify for themselves how connected they feel to female, woman, or girl on the scale from 0 to 10. Then how connected they feel to male, man, or boy on a scale from 0 to 10. And then once again, for other genders from 0 to 10. You could have someone hit 10 on all of these, 0 on all of these, or any variation within them. Gender expression, same thing from 0 to 10, feminine, masculine, or other. Now, within that, one of my biggest complaints about LGBTQIA plus trainings is that the needs of intersex people are often severely ignored. So I am going to touch base a little bit about the needs of intersex people, because intersex people are just, I don't want to say automatically, but because we're living in a binary world, the vast majority of intersex people are going to feel the symptoms associated with gender dysphoria. And that is really important to explore. Also identify who people are physically attracted to, 0 to 10, women, men, other, or emotionally attracted to, women, men, other, 0 to 10. Then we talk about physically attracted to. Like I've worked with individuals who were primarily sexually attracted to trans women who had breasts and a penis. There's no word to describe that sexuality yet. There might be a word, I'm just not familiar with it. But the point I'm getting at is there are different ways of living. And within that, making sure that we provide an environment which allows the individual to explore themselves. So I am going to differentiate really quick between transgender, non-conforming, and intersex. So for intersex individuals, what was the term we used to use when describing intersex individuals? Anyone want to throw that term out there? Jess, I saw your face move. What did you say?
Hermaphrodite.
Yes, yeah. Thank you so much, and I appreciate that. We no longer use that term because there is a lot of misinformation associated with that term. So we now use the word intersex because that's a better descriptor. So there used to be the belief that if someone, I'm going to use the word hermaphrodite, but if someone was a hermaphrodite, they were born with both male and female genitalia, meaning having a fully functioning penis and a fully functioning vagina. That is not the case. They only have one sex organ, and it's a mix of penis and vagina, X and XY. With that said, up to 1.7% of babies are born with sex characteristics that don't fit in with the typical definition of male and female. That's about the same amount of people out there who are living with red hair are the same number of people who are living with intersex conditions. So that's a lot of people. So 1.7% of the United States population, we have 360 million people. It's about 5 million people are living with this. And there's very little discussion about this. So really quick, we're just going to run through this. Like the term hermaphrodite is offensive and outdated. We don't use that. Now within that, it's a combination of sexual productive symptoms. Symptoms. So it could be some aspects of a penis and some aspects of a vagina together. And also it's a combination of neurological and endocrine related systems. A lot of times I see clinicians who are very passionate about working with trans people, and they will minimize the differences between those assigned male at birth and those assigned female at birth. And there are biological differences that we have to pay attention to, especially for providing effective treatment. So intersex people can't experience gender dysphoria. They're living in a binary world. They're not going to feel connected to male or female. Intersex individuals may not feel connected to LGBTA communities because it's not about who they love. It's not about their gender identity outside of the binary. And so they get lumped in, but they have unique needs. Now, I'm just going to go through this really quick. This is the Prater scale. On the far left, you would have what would look like typical female, and on the far right, you'd have typical male. So within this middle part, you can see things which vary outside of the traditional binary. So that doesn't mean we would assume that most people who are living with intersex characteristics are right here in the middle, but the truth is they're more within all of these. So it depends on their combination of XX and XY chromosomes. And the reason why I'm telling you about this intersex experience, because a lot of how we treat trans individuals has been learned from our work with intersex individuals. So before the 60s, there was limited research and understanding. And in the 60s, a lot of doctors were focused in on what they would conceptualize as like appropriate genitalia, and then use that genitalia to describe the individual. So therefore, medical doctors may have done surgeries on the client or on the baby without the knowledge of the parent, as the doctors were trying to have the child be within a binary. And the medical doctors did that because they honestly believed that was the best thing to do. Now, what we know, this is entirely different now. When we did that, we would scar the individual for life. It would cause PTSD, depression, urinary and sexual dysfunction, sterilization, lifelong hormone replacement therapy. Now, the current model for working with someone who's intersex is very close to the model of working with someone who's trans. So we use an affirming model. Sex is defined by a balance of factors. It's not just about what's between your legs. So gender identity exists on a spectrum. And within that, intersex is a natural human variation. A variation in gender identity happens in all levels of society. So gender is flexible and exploratory, and genital diversity can be affirmed. Children can be prepared and supported, and a wide range of sexual activity is normal and enjoyable within that. So there is no specific or single explanation as to why people are trans. Now, there are some discussions about the role of the environment, as we definitely see rates, different rates of non-binary individuals if we were to compare Ohio to California. Now, within that, there are a bunch of things which could be contributing to that, such as an environment which is inclusive, or an environment where people aren't allowed to talk about these things. Now, for the UCLA Williams Institute, there's about 1.4 million trans people in the US. Now, with that said, though, 55% of LGBT homicides are trans people. 78% of trans students report harassment, 35% reported experiencing assault, and 12% reported experiencing sexual assault. So this is a lot. Now, in the year of 2023, I think there were about 44 or 45 Black trans women who were killed specifically for their gender identity and their expression. When we think about the needs of trans individuals, we also want to conceptualize the intersectionality of how people from various marginalized backgrounds can be experiencing multiple stressors all at once. Now, information from the WPATH Standards of Care. So I'm going to give you the link where you can find this information, all right? So a disorder is something with which a person might struggle, but the disorder is not a description of the person. So gender dysphoria distress is the diagnosable concern, meaning that when I'm conceptualizing someone who has a gender identity, which is not their sex assigned at birth, I don't think of their gender identity as the problem. I think of the dysphoria, the disconnection, the potential victimization of bullying, worried about how to live life, all those things I conceptualize as the problem, not the individual within themselves. So a diagnosis does assist with care and can guide further research into effective treatments. What really kind of stinks is a lot of our a lot of research in regards to bisexual individuals, that research gets lumped in with gay and lesbian research. And so there's not enough research about all the letters within the LGBTQIA plus communities. So as I was saying before, for some individuals, their gender identity can be traced back to their earliest memories. They can feel dysphoria throughout their life, but they may not know how to speak about it. And the process of gender exploration is not linear. So the individuals can go one way or they can go another way, and we want to create an environment which is affirming. So gender identity and sexual orientation are not the same thing. So I would have people say, okay, let me actually back up. I feel terrible about admitting this story, but this kind of shows my own ignorance when I first started with this. I was working with someone whose sex assigned at birth was female. They identified as male. They did not want to have bottom surgery. They identified as male, and they also found themselves sexually attracted to men whose sex assigned at birth was male. So you have someone whose sex assigned at birth is female, who identifies as a gay male, wanting to be the top in a homosexual relationship. Now, I remember when I first heard that, my brain broke. And I'm like, wait, this person was born like from a female perspective. They don't want bottom surgery, and yet they want to be a top in a gay relationship. And I was so thankful that my supervisor treated me with like compassion. He didn't say, you are a transphobe or you're a homophobe or you're a terrible person for saying that. What he said was, Fred, let's hit the pause button. This may not make sense to you. This makes perfect sense to the client. Let's try to put yourself in their shoes. Let's try to understand where they're coming from. And let's take sexual orientation and gender identity away, because these are not the same thing. When he said that to me, that was extremely helpful. So trans people can have heterosexual identities, gay, lesbian, bisexual identities, but usually we use the client's gender identity as a reference from that to identify their sexual orientation. So a lot of trans people face pervasive and severe discrimination, high levels of discrimination in employment, limited health care, discrimination in education when looking for homes. They have higher rates of depression, anxiety, suicide attempts and ideation, and substance use. As I was talking about individuals who are from various marginalized backgrounds, we want to conceptualize the current systems in place, which can negatively impact them as well. So individuals from a racial or ethnic or religious minority, people from lower socioeconomic statuses, trans people with disabilities, trans youth, and I don't like to use the word elderly. I prefer to use the words more experienced populations. And I've been trying to change that word elderly or older adults to more experienced populations for like the last 20 years, and it hasn't caught on yet. So I'm hoping to do that. But the point being is I've worked with people who were out of the closet, whether there be their gender identity or their sexual expression. But as they aged, they needed to live in an assisted living environment. And when they got there, no one would understand. And therefore, they went back into the closet. It was very difficult. So within that, making sure that we conceptualize the unique needs of the individual. So people in general struggle more than white trans people. African-American trans people struggle more than all other trans populations examined, are higher levels of hate crimes and victims of microaggressions. Now, in regards to microaggressions, I remember I was doing this training a couple of years ago, and there was a trans person in the training, and they came up to me afterwards, and they appreciated everything I said. But I specifically said in the training, please, whatever you do, if you ever meet a trans person and they disclose that they're trans, please don't ever say, oh my God, I never would have noticed. Please don't say that, because what you're trying to say is you look great, but what the person is hearing is, oh, you look almost like you're a woman. That's not the same thing. And so the reason why I say this is right after that training where this trans person was there, they sent me a text later on that night saying that they went out to eat with people in the training. They disclosed that they were trans, and they had someone say that to them right there. So please, please don't say that. I mean, that is a microaggression. You're not trying to hurt the person, but what comes out is, I never would have guessed you were a guy, or something like that. Now, religious support for trans individuals. So the vast majority of people in the Northeast, maybe that's too high. I'm not trying to make that much of a bold statement. I would say many people in the Northeast are very liberal, and that's fine. Liberal, whatever you are. But with that said, I've worked with trans Republican Trump supporters. A trans person can have their own religious identity and their own political identities, and it's not up to us to try to tell them to change their identities. So I've worked with trans Muslims, I've worked with trans Christians. Within every situation, our job is to validate the individual and affirm the individual. Now, when we talk about disconnection from the LGBTQI communities, trans individuals have entirely unique communities. So the law changed, I think it was about 10 years ago in Connecticut, that legalized same-gender marriage. But prior to that, trans people were technically married. So my gender identity is my sex assigned at birth. So I identify as a male. I am heterosexual. I could be married to a female. And then while I'm legally married in Connecticut, I could have changed my gender identity. Now I am living in a lesbian marriage. However, other people who would identify as gay or lesbian were not allowed to get married. So there is disconnection. And also within that, I've worked with a lot of people who are like trans, they were not supportive of trans people. So I think about the trans exclusionary radical feminists, the TERFs, and I'm not trying to use that term like in a bad way, but one of my trans patients, she was very into women's empowerment. And she went to Lilith Fair. I don't know if anyone remembers what those are, Lilith Fairs. But she went to a Lilith Fair, and while she was there, like someone actually got on the mic, and please excuse my language, but someone got on the mic and said, there are some fucking tranny bitches here. We got to kill them. That was a woman saying that on the mic. So here's this person who identifies as trans around a bunch of people who might identify as lesbian who was not feeling supported. So this still happens. We cannot lump LGBTQIA+ into one big giant community. Now, creating an inclusive setting is key because we want to continue to validate the client. With that said, like validation, validation, validation. When I think about from the mental health perspective, I've heard people say the only way you can make people change is by making them feel uncomfortable. If that was the case, then we wouldn't have jobs. From a mental health perspective, we know that if we're trying to help a client obtain their goals, we got to provide the 6 core conditions of Carl Rogers, which includes having unconditional positive regard and creating an inclusive and affirming environment. That is the exact opposite of making the person feel uncomfortable. Now, with that said, a lot of my trans patients were concerned about discrimination from providers. I would see providers say the worst things, and they felt entirely empowered to do so, and they didn't really care about what they were saying. So therefore, a lot of clients would have anxiety about appropriate pronouns or bathroom concerns or knowledgeable and empathic staff. A lot of the trans people I've worked with, they were fully aware that their needs were unique. And with that said, if they worked with a clinician who may not have had all the experience, and even if they worked with a clinician who messed up pronouns, as long as they knew and were shown that that clinician really does care for them and wants to meet them, they had better outcomes. So this is a very old study. This was published in 2016, and I'm looking for more updated information. But within that, though, for transgender discriminatory survey, 28% experienced harassment in the medical setting. 19% were refused care. That number is actually much higher. I don't care what anyone says, and it's even higher amongst mental health providers. 28% postponed care as a result of discrimination, and 50% who received care had to educate the clinicians. So within that, I broke my elbow like a couple years ago. I couldn't imagine not going to the hospital because I was worried about how the doctor would respond to me. But that's a little legitimate concern for the individual whose gender identity would be outside of the binary or whose gender identity is not their sex assigned at birth. Within that, staff feel scared as to how to interact with trans people. And I've worked with tons of staff in various agencies who've reported their concerns about what do I do if I say the wrong thing? Well, when that happens, if you say the wrong thing, if you say the wrong pronoun, admit it and say, I sincerely apologize. My goal is not to hurt you. I'm working on this as well. And allow the client to provide any feedback if the client wants to. Some clients just want to keep going, but within that, show a full commitment to the client. So we can invalidate the client without knowing, can have judgmental responses to clients, inaccurate use of pronouns, and exacerbate negative statements. So I am a licensed mental health counselor. I'm trained in this. I have a passion for this. I respect that not everyone has my same training or my same passion. It is what it is. So when I worked at this one agency, I also had to provide training to our front staff. Our front staff were not clinicians, and they were like receptionists. And within that, they had some very judgmental responses to people who were trans. And I had to kind of pull them off aside and say, listen, I can't tell you what to think or how to think. But while you're working here, if you are thinking those things while you're here or acting this way, the client is going to feel it and it's going to have a negative outcome to the client. Is it possible that it is higher among mental health providers because many mental health providers want to refer somebody who is more specialized in that area? Just a thought I had. There are some things like adolescents that in private practice I will refer out because it's just not out of my comfort, or because it's not my comfort zone. So Hunter, I totally agree with that. I think there's a lot of value within that. This sounds terrible, but I was very lucky at all the agencies I worked at that I was never allowed to turn a client away. And if there are waiting lists, and I promise you there are going to be long waiting lists for people who specialize in this, if you accept the client and the client's on your caseload, you are obligated to then provide treatment to the client. So I appreciate you being here, and I appreciate your willingness to learn about this. I was very lucky. Like I said, I couldn't turn anyone away. And because of that, that forced me to get good at working with trans clients. So I do think that is a big part of it. And so, like you said, it's not your clinical expertise area. That's fine. Within that, though, I've totally just worked with people who are just afraid of trans clients. I'm sorry to say that. They were just afraid. They were afraid of getting sued. They were afraid of saying the wrong thing. They didn't know what to do. So problems experienced by treatment centers, a lack of health insurance or a limited ability for the health insurance to actually meet the needs of the person who's trans. Provider knowledge was extremely limited, and negative experiences in healthcare. As I was saying, postponed needed medical care. Now, delayed or ignored preventative health care. Like I've seen individuals who have put off taking steps for their gender identity for years because they're afraid of having to connect, and discriminated against by healthcare providers. I've worked with many medical doctors who would just say, "You're a man, you're a man, you're a man," and their attempts at or the ways of responding to that just tells the client that they don't care about them, and is more likely that the client is not going to return for treatment. So offensive statements, we do not say tranny, "Oh, you look like a real man or a real woman." We don't say that. We do our best not to invalidate pronouns. Now, with that said, I worked with people during their gender exploration where their pronouns changed drastically. Sometimes they preferred she, they, or then they wanted all they, them. Then other times they wanted these, theirs. So within that, we have to do our best. And with that said, honest reactions. We can have an honest reaction, which is invalidating. So, for example, I worked with this gentleman. His only way of having an orgasm was rubbing his face up against the hairy chest of a drunk man. He did not identify as homosexual, did not want to have sexual intercourse with people. This was his only way of having an orgasm. When I first heard that, my face was confused. And within that, I was invalidating to this individual. That was not helpful. Also, asking about sex, unless it's your job, unless you're the primary counselor, and it's your job to help the person on their path, you do not ask about how they have sex, and do not ask what's in between their legs. For the 60 plus people that are on here right now, if I were to ask anyone here what's in between your legs, that would be unconditionally offensive, discriminatory, and it could be viewed as harassment. So unless it's your job, do not ask. And also dead naming, that does happen. So I've worked with individuals who come in, all their medical records say Tim. After 6 months of working with Tim, and Tim now prefers the name of Lisa. And there's been times within that process that I've messed up the names. So within that, indicating that I've made a mistake and willing to continue to work on it, while also allowing any client to provide any feedback that they would have. So what I saw, like the majority of staff I worked with, they did their best. They did do their best when they were around trans clients. That doesn't mean that they didn't mess up. When they messed up, I provided them support, and they improved because I never provided support from a judgmental perspective. Within that, though, we cannot control what other clients will say. So if I was ever around and I heard clients saying, non-gender affirming things or things that could be hurtful, I would have to jump in and say, listen, you're allowed to have your own belief system. I can't tell you what to think, but while you're here in treatment, we do have an expectation that every client treat each other with respect and dignity. And so I can't tell you what to think, but I'm asking you to just at least change your words while you're in a common area. If you're in a session by yourself, you're allowed to say whatever you want. That's totally fine. But here we're asking that you show respect. We are obligated to do that. If we do not do that, that tells the client that their gender identity or who they are is not important to us. We have to remain client focused, be flexible, and educate our staff and reiterate client pronouns and expectations. Like I said, it's difficult at times. What helps me is, especially if a client is in the process of transition and the pronouns are changing, is before I would meet with them, I would just take 1 minute just to make sure I got the pronouns correct. Tim, boy, Tim, boy, Tim, boy, Tim, boy. That's what I would do, and then it would be fine. So I usually rarely mess up pronouns, but even despite all my experience, I still mess up pronouns. So obtaining information for the electronic medical record. So I do encourage you to ask the patient to identify their birth sex, because the sex assigned at birth is going to have a unique set of needs. And then ask the patient to identify their gender identity. You can have a free text space where the person can put their own words. And then ask the patient to identify their sexuality. Once again, free text that allows that. Now, with that said, a lot of electronic medical records I worked with were inflexible, meaning that the patient's assigned name stayed the same until anything formally was officially changed. So let's suppose the person has Medicaid, the person's name assigned to them is Tim, and they prefer the name Betsy. So within that, all of their medical documentation is still going to say Tim, but I made sure on every note that I indicated that Tim prefers the name Betsy, and we're going to respect her name and her use of pronouns. So I did that in every instance, and in every audit I've had, whether it be like Medicaid or like private insurances, every time they saw that, they all approved of what I was doing. So this is an example of an electronic medical record. At the top, you notice in red alert, transgender, female to male patient. So that was right there, right up front, to have people be aware to then use male pronouns. And you'll notice the first sentence, patient description is a 19-year-old neonatal female transitioning to male and prefers the name blank. And that's how I put that on there. I would start off every note documenting this. So therefore, there was never any problem. Every treatment plan used the client's preferred name and preferred pronouns. Now, physical changes to the office. I know it sounds ridiculous, but actually just having information about available LGBTQI plus resources, having that there shows that you care. And if you can have gender neutral or single occupancy restrooms, safe space flyers helps. Now educate staff regarding physical safety concerns and assure that feedback is welcome. And with that said, I'd encourage, like, I can imagine there's people here from several different agencies. Try to have one person at the agency who's primary their job to make sure that they create an inclusive environment. Now, I've seen a lot of places which would say that they're very inclusive and they would have the flyers, but yet within that, they weren't flexible to client needs. They would get frustrated if a client challenged them. So this is more than just the putting up the sign. This is actually a cultural shift in the actual center. Also, try to have an official office protocol, have like available written set of rules in every agency, specifically indicating that your agency has a commitment to respecting each individual's identity and will use words that are alignment with the client's requested identity. So appoint a staff liaison and educate new staff. So if you are working with any trans clients, and even if you're not, I would still encourage that you would have yearly trainings for staff. And then have a formal response for invalidating statements. So I've had people get mad at me like my response has always been, I sincerely apologize. I can imagine this was difficult for you. I'm here to receive any feedback. I just want to affirm my commitment to working with you. Some people said, that's way too much. When you mess up, you're just supposed to acknowledge it and keep going. But I've worked with, I'm DBT trained, so I've worked with a lot of people with borderline personality disorder. And so if I went that oh, okay, I messed up, I'm sorry. If I went that route with them, that would totally exacerbate symptoms. So that's why my response is a little more in depth. I'm not saying that the other minimal response is bad, but it depends on what's appropriate for the client. So as I was saying, use safe space markers, engage in staff's training, and encourage open dialogue with clients to discuss times if they feel their gender has not been validated. And also allow staff to talk about their concerns. We can only be really supportive on this if we have an open and transparent discussion. Also, I see a lot of places say that they are trauma-informed. Oh yeah, my clinic runs trauma-informed care. And there is a way you can tell if your clinic is not trauma-informed. That's when people are not allowed to talk about trauma. So you could have a lot of places say, like, we support LGBTQI plus needs, and within that, there's no dialogue about that. So try to have that dialogue. Try to have someone there who's infusing the dialogue. And like I said, no one's perfect. I'm continuing to learn. And our current literature and research is still imperfect. We're still studying this. So a lot of people have worries about making a mistake. That's fine. There are concerns about invalidation. Mistakes do happen. Openly discuss mistakes, affirm client feelings, reaffirm a commitment to work with the client, and accept feedback. I worked, so I was running groups for individuals who were living with borderline personality disorder, and I had a patient in the group who was trans. I would guess that many other patients in the group were able to tell. They never said anything. But one of the psychiatrists accidentally outed the trans patient in the group session. That's not supposed to happen. So we have to leave it entirely up to the individual if they want to disclose their journey or how their journey goes. But the psychiatrist, they totally did not mean to do it. And they did not know how to respond. So I made sure I had the psychiatrist reach out to the individual and apologize, and also provide an open position for the client to talk about their experience. A lot of times in clinical treatment, there's the aspect of rupture and repair. Ruptures happen in every therapeutic organization and in every therapeutic relationship. But the repair is equally as important because it helps people develop new skills as to how they can manage it. Now, interactions between clients work to prepare client in cases of inaccurate pronouns. So if you see clients using inaccurate pronouns, do your best to then just reaffirm the pronoun, and may have to provide some education to assist clients. So some people may not understand that aspect of what it means to be outside of the binary. Allow the client to disclose on their own terms. Do not remain silent during harassment, and be willing to hear client frustrations. Now we have about 15 minutes left, but I am going to touch base about like different aspects of treatment. But this whole thing, like I said, this is usually an 8-hour presentation, and I could spend 8 hours specifically talking about treatment by itself. Now, I'm originally from Buffalo, New York, so I'm a huge Buffalo sports fan. So I love the Bills, and they always break my heart whenever they lose. I'm a huge Sabres fan, even though they've sucked forever. But as I was saying before, a lot of trans clients might view you as a mental health provider as a gatekeeper. And therefore, they don't know what to say. They don't know what to withhold. They lack trust in the process. And they themselves don't have information about the standards of care. So within that, I've had a lot of clients who were worried to tell me about their mental health conditions that they were living with. And they're also worried to talk about substance use problems. So with that said, I cannot stress enough. A client can be living with any co-occurring condition, including any mental health condition, which includes schizophrenia, or any substance use disorder, which would include opiate use disorder, specifically for fentanyl. And those diagnoses would not prevent the client from getting affirming care. Once again, the client can be living with any mental health diagnosis and still meet criteria for affirming care. There might be some discussions as to how we can improve those conditions while the client is on their path, but no diagnosis will disconnect a client from affirming care. So from the standards of care recommendations, if you are the primary clinician who's working on gender transition, you have to have a master's degree. You have to have competence using the DSM-5, recognize and diagnose coexisting disorders, documented supervised training, knowledge about alternative gender expressions, continuing education, and cultural competence. And it's funny because I've been doing this for so long, and I've done so many trainings. I do tons of continuing education about this as well. But I have provided so many trainings that now when I do trainings, I see people using my own slides back to me, so which is kind of funny. So it is what it is. But issues that have to be discussed: access to health services, the history of patient problems, endocrinology, issues related to safe sex, HIV, sexually transmitted infections, substance use history, mental health related problems, and overall health and wellness. Now, when we talk about issues related to safe sex, a lot of trans people I've worked with, they may have been disconnected from their friends or family because of their gender identity, and they also may have lost their jobs for coming out. So they had no income, and many people I worked with had to engage in sex work. As a result, we had to have a discussion specifically about how to be protective within those areas. Also within that as well, too, we've had to work with people who were in domestic violence relationships because they were in a relationship with someone who affirmed their identity and yet would have instances of domestic violence. So these are pretty heavy conversations within that, making sure that we do not ever judge or discriminate against a client while we're having these conversations. Now, there's different options for treatment. So changes in gender expression and role. So I've worked with a lot of people who did not want to formally change their name. They did not want to get any surgeries. They did not want any hormones. They just wanted to live the way they identify, and they wanted to have people call them a specific name. That's it. That might be good for some people. Other people might want hormone replacement therapy for feminization or masculinization. Other people wanted surgeries, and that's not a one size fits all. And within that too, I've seen discrimination within the trans population, where if someone was just living in their intended role, someone who may have had the surgeries and the hormone replacement therapy might look at this person and say that they're lying. So we have to make sure that we even assess for discrimination within the trans community itself. One of the big things I work on are options for social support, in-person or online peer support resources. Like I said, individuals are still being discriminated against, and as such, they are disconnected from their friends, family, jobs. So we need those kind of connections. Now, within that said as well, surgeries might not necessarily help vocal therapy or vocal operation. So trying to be connected with the hearing and speech therapists. Now, hair removal through electrolysis or laser treatment, like breast binding or padding, genital tucking or prosthesis, padding of the hips, and changes in the name and gender marker, or and other identity documents. Now, working with families. So rejection can increase the likelihood of suicide attempts. Now, I just want to be entirely honest. I know that the Northeast is not a representative is not an accurate representation of how the entire United States would respond to working with transgender children. But does anyone want to take a guess? Out of all the parents I worked with, what percentage of parents were okay with their child having a gender identity that was outside of their sex assigned at birth? If anyone wants to take a guess, from 0 being none of the parents were cool to 100% to all the parents were cool. All right, 3%, Hunter. That's a great guess. Manchester says 20%. 10% for Susie. All right, that sounds good. So I understand that my response is not in alignment with every response throughout the United States. The truth is, working outside of New York City, 95% of parents I worked with were entirely supportive of their child. With that said, they were so supportive that they were trying to rush the child into surgery as soon as possible. And my job was to help slow them down to allow the child an opportunity for the child to explore who they are. So I respected that all the parents I worked with, the vast majority of parents I worked with, were trying to support their client, but within that, they were still trying to force the client within a binary. And then when I worked with parents who were not affirming, I did not treat the parents as if they were bigots or bad people. I treated the parents as if they really cared about their child and they wanted to make sure that their child was okay and would have a successful life. So we'd have to do some therapy to talk about the process of what the parent was experiencing. Now, for hormone replacement therapy, when you are doing letters for hormone therapy, you have to have a persistent, well-documented instances of gender dysphoria. Also, the capacity for fully informed decision-making. The individual has to be the age of majority. If significant medical or mental health concerns are present, they have to be treated. And presence of coexisting mental health concerns does not necessarily preclude the individual from hormones. Now, with that said, when talking about hormone replacement therapy, I just want to say that what I'm going to say is offensive to people who are very supportive of people of transitioning. The truth is, hormones do have side effects. Hormones do have side effects. So a lot of times people assume like that hormones, they don't have side effects. And I will prove to everyone right now as to how hormones have side effects. Does anyone here remember going through puberty? And how would people describe that experience of going through puberty? Anyone want to put in the chat or jump in?
Crazy.
Crazy. Okay, I appreciate the honesty with that. Yes, absolutely. Horrible, confusing, a roller coaster ride. Yes, absolutely. Overwhelming. So I'm not trying to be offensive with this, and please forgive me. I'm not trying to come at this like from a position of like I don't want to be like a masculine person from saying this. So I'm going to talk about the experiences of people who have a sex assigned to them at birth as female. So for the females I've worked with during puberty, the estrogen caused them to experience emotions in a much heightened way. In addition to that, they had different bodily changes. Now, for people whose sex assigned at birth was male, when they were experiencing puberty, the introduction of increased testosterone created more irritability as well as increased horniness or sexual drive. So these things do happen. So I have, let me stop sharing. I want to share another thing with you really quick. Share screen. Let me see. Okay. I have information specifically about the benefits and drawbacks of hormone replacement therapy. So I provide all of my clients with this information. Now, I am not an endocrinologist, but I give this client information to make sure that they have some information about what they're requesting. Now, with that said, according to the WPATH standards of care, you're allowed to receive hormone replacement therapy the first time you see someone. But with that said, though, usually I would ask the client to at least get some blood work first because hormones can impact the body. So, for example, I was working with this one patient. He was like in his late 40s. When he was 6 years old back in the 70s, he told his mom, I'm not a girl. My name is Jay. I'm a boy. I'm going to be a boy. And mom just went with it. So when mom enrolled him in school, everything just said boy. And there was like, they didn't need to do any formal it just went through. It was like his experience was entirely different. So he just was living in a very affirming life. So I met him in his 40s. He was interested in getting hormone replacement therapy. And he had never had an OB/GYN appointment. Never. And I mean this in the nicest possible way. Someone who's trans man, asking them to have an OB/GYN appointment is like asking them to do something extremely offensive. But as they never had this appointment, this part of their body was never taken care of. And we did some motivational interviewing, and I was very lucky to get him connected with an awesome, wonderful, affirming gynecologist. And that gynecologist did such awesome work. But within that process, they found that this person had precancerous cells that had testosterone been introduced, it actually could have turned into cancer. So when conceptualizing hormone replacement therapy, we have to conceptualize the whole person. This isn't only about their gender identity. This is about their health. This is about their mental health. All these things have to come into play. And that's why I give this information. Now, I was doing a training on this over the summer, and one of the people in the training was also trans themselves. And afterwards, they came up to me and they said they wished they actually had someone give them this information before they took hormones. Also within that, as the individual will experience a different way of being when they're going on hormones, I usually talk to them about the benefits of maintaining continued mental health treatment as life is changing around them. Now, the bad news is we only have a few minutes left. I'm so sorry, except I have to be done like around 1:15, so I'm going to shred through a bunch of stuff. Please forgive me. But I just want to let you know, I'm going to give you a link for the WPATH standards of care. I'm going to give you information about hormones. And I'm also going to give you examples of letters as to how to provide support. The bad news is I did not even talk about like any mental health treatment aspects. So as I'm a CBT guy, I use cognitive behavioral therapy. I'm going to just touch on that really quick before we go. Go back to share my screen. Okay. All right, so can everyone see the slideshow because it's not showing up on my screen? All right, thank you, Darcy. I appreciate it. So let me just fast forward. Okay. So, all right. From a clinician perspective, we have to treat the individual like Carl Rogers. judgment-free, fully affirming of the individual, and provide unconditional positive regard. Like I said, we use the aura skills, open-ended questions, affirmations, reflective listening, and summarizing. Now, a lot of common statements I have worked with clients, they experience, no one wants me, I'm not a real man or woman. I'm sorry to say that, but I've heard that. I can't have kids, people will judge me, people can read me, I will never be happy, I can't have a relationship, I won't get a job. And if I were born in the body I wanted, things would be better. These are all, although they might seem entirely real to the individual, all of these can be respectfully challenged through the CBT process. So if they would say, no one wants me, I would ask, I would, I would validate their statement. And then I would say, well, have you known of any other trans people who have found love? And the answer is yes. I'm not a real man or woman. I would say, what does it mean to be a man or a woman? And within that, I'm going to ask everyone else here, like, although my sex assigned at birth is male and I identify as man, if I were to be driving home today, and please God, don't let this happen, if I were to get in a car accident and only my penis were to be chopped off in the car accident, would I be any less of a man? Most people would say no. So we challenge these thoughts to have the client identify different ways that they could connect with themselves. So there's so many, I mean, this is my like CBT worksheet. Feel free to use it, but I'm so sorry, just because for the sake of time, we are running out of time. So having the chat. Just in case some people aren't aware, Social Security quietly changed the requirements to change gender identity within them. Their only requirement is the individual statement that they are the gender they identify as, and costs nothing. So thank you, Jess, for sharing that. And particularly within that, in New York, Medicaid has helped to cover surgeries as well. The only bad news is not every clinic will do that, and you just have to be on top of that. So, all right. So with that said, I'm sorry to just rush to the end. Okay. In closing, trans people exist in all levels of society. They have multiple, multi-dynamic problems and needs. Gender and sexuality are not the same thing. Transition can be difficult or lengthy, but it's also supposed to be individualized. It is okay to ask people how they would like to be referred to, and do not do the golden rule. The golden rule says treat people the way you want to be treated. Give them the platinum rule. Treat clients the way they want to be treated. Now, with that said, I would like to just stop sharing my screen. Oh, here's my information, and this is my dog, Tanner. So he's a Chiweenie. Feel free to reach out to me at freddombrowski@gmail.com. And I'm always open to receive feedback. I mean, I know there's things I may have said in this presentation which we will eventually find may not be entirely accurate. I'm open for any feedback. But with that said, before I let you go, for everyone here who's working in the human services field, regardless of the type of patient that you're working with, we are living through unprecedented times. You have chosen a life where you're trying to help people. And that doesn't mean you have to like all the people that you work with, but you've still chosen that. In addition to that, we're not going to know how severely this pandemic has impacted us for about 50 years afterwards. Because you are who you are, I cannot promise you enough that you are making a difference. Who you are and what you are doing truly does matter. Even when clients are lying to you, even when it doesn't look like they're making progress, I promise you, every 1 minute you spend with someone where you are giving them unconditional positive regard and creating an affirming environment, you are allowing that individual an opportunity to improve their lives. I cannot thank you enough for allowing me to spend this time with you today, because I know you're busy. But please feel free to reach out anytime, and please do not give up the wonderful and amazing work you do. I have about like 4 minutes for questions. If anyone has any questions or anything you want to say before I let you go.
I have one question.
Yes.
It's kind of like a what's your opinion? The DSM criteria for gender dysphoria, it's very binary in the fact that it specifically asks questions like if somebody's playing with a certain gender toy mostly, or if they're having friends who are mostly of this gender. Do you see that changing? Because I find that just weird.
Yeah. So like that's a very two-dimensional assessment.
Yeah,
I do expect that to change, absolutely.
okay,
Especially as we're getting better information about this.
yeah,
And within that said, I respect why people would have concerns about the DSM, but the DSM's job is to try to make sense out of things that don't make sense.
yeah,
As we continue to get more information, I would expect it to improve.
okay,
But they need our voices though. So they need people to advocate for that. So when the DSM-6 is going to be coming up, they're always looking for people. So please provide your feedback if you have any concerns about diagnosis. With insurance for surgeries, does Connecticut have any requirements that they may be covered for all types of insurance? I don't know about the specific Connecticut law, but I do know as a provider, I have been able to connect directly with insurances and advocate about some connective care. And then I usually take that from a perspective of reduction of overall costs to the provider. What does that mean? If the individual has taken steps, they have become aware of the benefits and drawbacks of hormone replacement therapy, but the insurance may struggle to connect with that. I could possibly talk about how doing this will actually cost less money because the client will be less likely to engage in self-harm or whatnot. So I have been able to advocate with insurance companies, and I've seen some insurance companies have flexibility. All right. If there are no questions, please feel free to reach out to me. Like I said, I sincerely appreciate everyone here. Thank you so much. Feel free to connect at any time. Have a good one. We'll talk to you later.
Thank you, Dr. Dombrowski. Great having you.
My
care.
pleasure. And I'm always feel free to reach out to me anytime. Like I said, DBT, motivational interviewing, CBT. Gosh, I'm like telehealth, I could talk about anything. So
Wonderful. Thank you.
have a good one.
You too.